So now I'm going to talk about common clinical trial designs. So the next few slides provide some general categories under which clinical trials may fall. And I've also provided you with a few examples of each type of category and the links to those clinical trials on the clinicaltrials.gov platform, which is a website that you could go to and determine if there is a clinical trial that you're interested in, if it's been done, or if there are any ongoing trials. So we can think of trials falling into exploratory phases or exploratory types of trials. We can have trials for treatment. We can have trials for prevention. An example given for prevention may be one to determine if a home-based wellness coaching delivery approach is more effective in reducing obesity, say compared to some other standard approach that might already exist. We can also have screening trials where our goal there is to evaluate the effectiveness of different screening modalities for a specific measure. In the example given here of a randomized clinical trial to compare the effectiveness of a low-dose computed tomography versus chest radiography screening in reducing lung cancer-specific mortality in patients who are at risk for developing lung cancer. Again, it's a clinical trial because it randomizes people to either the low-dose tomography or to the chest radiography, and it includes a measurable outcome and therefore in a reliable population, and therefore would be viewed as a trial with internal validity that could prove the effectiveness of the intervention. We can also have diagnostic trials to compare different types of diagnostics for a variety of outcomes, diseases that we're interested in. And then we also have quality of life trials. This is kind of a more recent addition to the repertoire of clinical trials. But here we could be interested in randomizing groups to one form of intervention versus another to evaluate a measure on subjects' quality of life. This is an important area that's growing due to the need for having more patient-reported measures in clinical research. So now I'm going to discuss some common trial designs. The first is the parallel design. This is a design that has two or more groups who are randomized and they're followed in parallel simultaneously. This is the most common trial design for clinical research. All individuals in this trial have the same baseline and the same point of randomization. And the timing of the primary endpoint in these trials is fixed, and it's the same for all randomized subjects. Here's an example of a two-arm parallel trial design. Again, all subjects have a baseline period and then the randomizing period, and they're followed concurrently in either group depending on what they're randomized to, and then the primary endpoint is measured. You could also take that and extrapolate it to other types of interventions. In this particular parallel design, you're comparing two groups, one that received the standard of care and the second group that received the standard of care plus the treatment. And again, it's a parallel design, but it would be considered an add-on treatment study with the goal to evaluate the effect of that new treatment. And the reason why you have the standard of care in both arms would be because it would be unethical or inappropriate to, say, randomize patients to, say, a placebo-only arm. This is an example of a dose-response parallel design, which again, all arms are followed simultaneously, but the difference here is you have multiple treatment doses for the new treatment, and you still have a control arm because that's very important for internal validity. And the purpose of this design would be to evaluate the effect of the different doses as against the control, as well as to look for the minimally effective dose. There are many variations of this type of trial design, and the premise is to start with few or single patients at the lowest dose to observe if any toxicity occurs. And then if no toxicity is observed, then the next dose is introduced, and that process is followed until a dose is reached that's viewed as too toxic for the population. This design can also be utilized to evaluate a treatment effect. Usually it starts in the other way. It starts at the highest dose and it works downward and to the point that there's a loss of treatment effect. This shows you an example of a dose escalation trial it is a parallel design, but the difference between this and the last is that with each new dose, there is essentially a new cohort that's randomized and followed. And so these groups don't all start at the same time, but they all have the same follow-up time, and they're all compared against the placebo group. The next big category of clinical trial designs is called the factorial trial. This was coined because of the use of covariates are considered factors. For example, a single treatment versus a combination of treatments. And in this design, experimental groups are arranged to allow testing if the combination is better than individual doses or individual interventions. So this design is used to test the effect of more than one intervention or treatment. For example, 2 doses of the same biologic. Or, for example, combinations of drugs such as X, Y, and Z versus the combination of just drugs X and Y, which are common sort of designs in the treatment for HIV. These designs allow for the assessment of an interaction among interventions, and they're considered the most efficient, statistically speaking, due to their design, and they do not require as many patients as a parallel design. Most simple design is a 2-treatment one of A and B, and that is then done in 4 different treatment groups. This sort of design allows the testing of A alone, B alone, and A plus B, all versus the control. And then you can generalize this approach to higher designs. So here is an example of that 2x2 design, looking at the effect of drug A, drug B, and then the combination of the 2. And then here's a more complicated design of a 2x2x2 design, where now you have 3 drugs you're interested in studying simultaneously. Lots of examples of factorial designs in the literature. There was a large physicians' health study of over 22,000 physicians to test the effect of aspirin on reducing cardiovascular mortality, the use of beta-carotene on reducing cancer incidence. And this was a noteworthy trial because it tested interventions for unrelated diseases and used physicians as subjects to report the outcomes. Another example would be that it was a 2x2x2 trial to assess the efficacy of 3 different interventions among patients with a suspected myocardial infarction or a heart attack. And this was a doable design because there was no interaction assumed among those 3 treatments. This had a very large sample size of 58,000 persons. The next design is a crossover trial, and this is a standard 2-sequence treatment crossover design shown here. And the key aspect of a crossover trial is that all patients are randomized to one or the other intervention, and then there's a period of which they're assessed, and then they're stopped treatment, and then they're given the other treatment that they could have been randomized to. And the beauty of these designs is that each patient serves as his or her own control, and so it eliminates intersubject variability. Now, the crossover trial has lots of advantages. It's more economical in terms of the number of subjects required, and as I just said, it reduces within subject variability. However, the disadvantages are that they're difficult to analyze if there are large numbers of dropouts in the trial. The order of the treatment received can sometimes bias the results because dropout may occur subsequent to the first treatment. And depending on the drugs studied or the intervention studied, there can sometimes be a carryover effect from one regimen to the other. And these designs are viewed as sometimes inconvenient to subjects, and they're more complicated to analyze. These are designs that are typically used in phase 2. It's very challenging at times to determine the period of the washout for a crossover trial, and that has because of the sometimes the lack of true understanding of the overall exposure period for the first drug that's received. And you can also have factorial crossover trials in which subjects receive more than one treatment, and we are also interested in studying multiple treatments in the same design. Those are more complicated. This illustrates an example of a two-sequence dual crossover trial where subjects are switched not just once but twice. And now I'm going to talk about an N of 1 clinical trial. This is truly an N of 1. It includes one patient. And the idea here is that that one patient is evaluated in multiple crossovers. So they randomized to receive one treatment, and then they're crossed over to the other treatment, and then they're crossed back to the first treatment, and then to the second treatment. And that's repeated over and over, and each time there's crossover, there's an evaluation. And the idea being that each observation is an individual time. Each time the patient switches treatment, that's a new observational point. And so useful designs for studying a chronic condition with a stable response, a quick onset of treatment effect, and has modest carryover. These are not useful for studying acute or progressive diseases or any sort of situation where treatment might cause permanent or reversible effects, such as an oncologic treatment. And they're not useful, obviously, for prevention treatment. So the last type of trial I'm going to discuss is the community or cluster trial. Here, randomization of intervention is done at the group level rather than the individual level. These trials are more robust than the individual level randomized trials, and they're less difficult to perform from a logistics perspective. They're typically used to evaluate the effect of a community intervention. And the reason we randomize groups instead of individuals in these settings is that it's not feasible or practical to randomize individual subjects because subjects in an area share too many characteristics. So for example, if we're interested in evaluating the effectiveness of water fluorination in a community, it would be impossible to essentially randomize individual homes because homes nearby each other receive water from the same water source. And so in this case, we would instead randomize homes or groups of homes and into one exposure and another group of homes to a different exposure. Another example would be a trial to provide vitamin A supplements to communities in developing countries. And there's another example provided here of the COMET trial, which was a community intervention trial to evaluate smoking cessation. And here they enrolled 11 communities and to either some sort of community level intervention or a comparison group. These trials are performed when intervention is difficult to restrict to the subject level, as I said. Also when there's a desire to reduce stigma because everyone in a community or group gets the same exposure and the same treatment. It also reduces self-selection bias, thus enhancing the generalizability of the results. And it also allows for greater assessment of population level effects. But they do have limitations, including the lack of comparability between groups due to fewer units of randomization. So there's more correlation among individuals in a group. And henceforth, these studies require much larger sample sizes to deal with the limitation with respect to the individual lack of individual-based randomization.